So thanks a lot for the introduction. As you already said, I'm Dr. François of Colonel François, no matter. As you see, this is Med-LCL, medical of médecin, lieutenant colonel, lieutenant colonel, so a colonel with 2 stars. But anyway, it doesn't matter. You are not interested by that. You are interested by the facts. So what am I going to talk about? What is a military doctor, in fact? And before to talk about that, what is military medicine in general? And there are a lot of confusing things about that. People have a lot of ideas coming from the movies, coming from the phantasms sometimes. And that's the reason why we will do it from the dream to back to reality, with the positive points, and also we will be honest enough to talk about the negative points also. I have to be honest. I have to be honest because my first dream, my first military dream was not to be a doctor. It was to be a pilot because I belong to the generation, Top Gun generation, not for the girl, but for the planes. And unfortunately, I had a view problem, and that's the reason why my second choice was doctor. But I'm very happy with that, trust me. Something else, you will very easily understand that I'm quite ironic. I like my job, I like my country, I like the medical component, but I like humor also. And that's the reason why I'm a little bit too much ironic. So all the views that I'm going to express are absolutely personal, of course, in close accordance and in of the medical authorities. Who am I, in fact? I am what I am. So, Pierre-Michel François, Pierre-Michel Christian name, François family name. I was graduated as a doctor in '99, so a very long time ago if I ever look to the young people here. After graduation, I was sent in Germany as general practitioner. So I was not immediately a specialist. I will explain that later. I worked during 3 years as general practitioner, as family doctor in Germany. There were Belgian troops in Germany, in a reconnaissance combat battalion, and it was, I should be honest, it was the best 3 years of my life, the happiest 3 years of my life. 2002, back to Belgium, and I always asked to do something about critical medicine. But critical medicine, it can be anesthesiology, it can be emergency medicine, it can be critical care like intensive care, something like that. And I had the opportunity to start a residency in anesthesia and resuscitation, so a specialization of 5 years. I did it in the civilian sector, because we don't have our own medical military faculty. I did it in civilian sector, in UCL, and it was followed by a fellowship in our emergency and disaster medicine. So 6 years of specialization. After that, I arrived in the military hospital, and I started to work half-time for the army, because I will explain that, and my colleague will explain that later. Nobody is working as doctor, as medical technician, full-time in the army, because we need to entertain all skills, our technical skills, and that's the reason why we need to go half-time in the civilian sector. And half-time military hospital, half-time in the emergency department of UCL. I decided to reorient my career in 2015, and I had the opportunity from the defense to make 1 year of fellowship in intensive care in order to get the title of ICU specialist also. I went back to the military hospital, to the burn center. I became head of department of the burn center there for 4 years. And then I moved to CCMed. This is the center, the competence center, competence and training center of the medical component. So as you see, our career can be very evolutive. I should say much more than in the civilian sector. I came back to anesthesiology, not anymore in the emergency, but I came back to anesthesiology, and I'm doing an half-time in anesthesiology department. What about operational missions? Because you want to see blood, you want to see guts. Okay, I'm going to show you. And I made several missions, Kosovo, Afghanistan twice, 2004, 2014. I don't think I'm going to go in Afghanistan in 2024. It's going to be quite difficult, I'm afraid. Lebanon, 2 times aboard on the frigate, combat frigate in the Indian Ocean, in Iraq for the Battle of Mosul in the north of Iraq, and the last time it was in Niger. And you can see some beautiful pictures, but I have more beautiful pictures. There is a big problem. The army has a bad reputation. There are a lot of rumors. The majority of them are false. Some of them are true, I have to be honest. But don't trust what they show, don't trust what they say. We know we have this problem of bad reputation, of the stupid guys and so on. There are a lot of stupid guys in the army. A lot of idiots, but not much than in the civilian sector. And every military man has been a civilian guy before to enter into the army. Remember that. And also, the military medicine has also sometimes a bad reputation because we cut everything. We're making amputation to everybody and so on. We don't make any follow-up to the patient. Trust me, this is not true. There are also some phantasm about the combat medic who is going to go to hell to save you and so on. Whoa, stay quiet, please. So, in fact, what is military medicine? Is military medicine war medicine? Yes and no, because people working in NGOs like Doctors Without Borders, Médecins Sans Frontières, these people are also doing war medicine. So military medicine can be, from time to time, war medicine. Military medicine, I talk about operational military medicine. Military medicine can be quite symbiotic with what we call wilderness medicine. Wilderness medicine, this is a medicine in, I'm deeply sorry for the word, in the fucking middle of nowhere, with very limited medical supply, medical tech possibilities, medical technologies, because there are a lot of medical talks about the last up-to-date technologies. We don't have technologies. We are making medicine boots on the ground. And boots on the ground, I mean boots in the mud, boots in the sand, and so on, with very limited technology. But we need to be polyvalent. We need to be versatile. That's maybe one of the definitions of the military medicine. And so the real definition is military medicine. This is the medical support to the military guys in an operational setting. And sometimes we have the possibility to do humanitarian medicine in the same time. I will show you some pictures and some slides about that. Some people are doing occupational medicine, medical preparedness of the military forces. This is not my cup of tea. I'm not going to talk about that. Mostly, this is curative medicine from the point of the injury of the patient to the evacuation back to home, back to a Belgian hospital. And we have to guarantee what we call a continuum of care with the same quality than in Belgium. It is not very easy according to the circumstances. And we also focus about the medevac, the concept of medevac, medical evacuation. It can be a casevac, casualty evacuation from the point of injury, to a stratevac, strategical evacuation of a wounded guy back to Belgium. So military medicine working in an austere, sometimes hostile, dangerous environment, with logistical supply very often limited, not always oversized. Very short slides about history, because I like history and because it's in order to show you that there is a close relationship between military medicine and some medical progress. Because it's absolutely awful, but when there is a war, there is a need of medical improvement because there are a lot of wounded people, the killed people and wounded people. And that's inducing an intellectual response to improve the quality of the medical care. That's the reason why that when we start from the Middle Ages, everybody knows maybe Ambroise Paré, a famous surgeon. He was not a cardiac surgeon and so on like today. No, he was a barber surgeon to trim the beard and to close the wounds. This was the role, the function of a barber surgeon at this time. And so the war medicine guaranteed only trauma care, close the wound, no control of infection and so on. So you can imagine that the majority of the people that have been wounded died from secondary infection. The first concept of military medicine was done by the French army during the Napoleonic War, because they started to organize something that we call the concept of health officer. He is a doctor, And in the same time, he's a military guy, he's an officer, and is in charge of the organization of the medical chain and of the organization of the medical cares on the field and after the field. It was the first time that the doctors had to organize something. And even now in the civilian sector, it's not always very evident. You know, the doctors are very good to treat patients, but not always to organize something. I'm deeply sorry. I'm a little bit jokey, but not that much. And they started the concept of triage, sort the patient according to the priority. It was the first time. It was revolutionary. And also, they invented the evacuation by ambulance. Of course, we are talking about horse ambulance, and also the battlefield care, not to evacuate directly the patient, but to perform the cares on the battlefield in order to avoid, to stop the hemorrhage and so on. And they made very precise description and very good protocols of amputation, for example. Always amputation, but with very few asepsy and so on. So there was a huge over-mortality coming from the infection. No antibiotics at the time. 19th century, colonization, a lot of tropical doctors were military doctors. If you know about Yersinia pestis, the pest, Yersin was a French military doctor, in order to give you an example. Crimean War, Florence Nightingale, she was not military, but she was present, and she saw that, okay, there were quite good trauma medical care, because about 16,000 deaths, there were 16,000 deaths from illness and 2,006 by injury. So the trauma care were quite good, but there was absolutely the medical officer was not interested by the medical cares. And so she decided, okay, there is something to do, and maybe there is a missing link between an ambulanceman and between a doctor. Someone who can make the cares and who can provide also hygienic things and so on. And that's the nurse. Solferino, everybody knows that, Arundina, the founder of the Red Cross. American Civil War, first so-called modern war, and the first civilian ambulance were done by people coming back from the war, because they saw that it was working. World War I, I will not read everything, but as you see, the concept of triage, the concept of early surgery, first use of radiology on the field, anesthesia, of course, I like anesthesia, blood transfusion of the field was done for the first time by a Belgian military doctor also. World War II, huge use of morphine, maybe a little bit too much, antibiotics. The American soldiers came with antibiotic, with penicillin, and the German soldiers had only sulfamides, no penicillin, anesthesia, of course, and they also improved the quality of surgery. Korea War, first use of helicazévac. They decided to make scoop and run. When you are wounded, you need to go as soon as possible to an hospital. With an ambulance, yeah, but the ambulance, the ground ambulance in the Korea, it was limited. That's the reason why they decided to make casualty evacuation. So you see, you put the patient on a stretcher on the side of the helicopter and you evacuate it as soon as possible, without any medical cares, of course. That's the reason why a lot of patients arrived at the hospital, but they arrived dead. So it was a little bit awful. Hemodialysis, maybe the medical students, you know, the hand-tan virus. The hand-tan virus is inducing hemorrhagic fever with acute kidney injury. The first hemodialysis was done in, a reserve medical officer coming from the United States, and he was on duty in Korea, and he decided to perform, it was absolutely, it was still research, and he started to perform hemodialysis on young soldiers in Korea. And thereafter, he came back in America, and he started to publish about that. Surgical timelines, not very interesting for you. Vietnam War, the concept of the combat medic. Actually, when we are talking about the paramedics in the United States, they are coming from the combat medics of the Vietnam. On-site medicine, stay and play, because these people are able to put IV, intubation, pneumothorax, exsufflation, so it was not anymore we take the patient and we evacuate him. No, we stabilize him before evacuation. This is what we are doing in Belgium and in Western countries with the MUC, the SMUR, the SAMU, and so on. This is the concept, the application of this concept. War on terrorism, enduring freedom that just finished in Afghanistan, and Operation Iraqi Freedom. We developed the concept of TCCC, Tactical Combat Casualty Care, and today you will have the possibility to play with the T3C during this day, and you will see that the concept is to give appropriate care, but very quickly and not to lose any time to stay and play. You will see. It's very interesting, but quite difficult to do because as young doctor, you want to perform a lot of things. No, you don't need to. Clinical practice guidelines, damage control resuscitation. I will focus about that because if you save people, if you save polytraumatic people, this is because you do damage control. This concept is a pure military concept that has been adapted to the civilian sector after that. Care, T3C, you will see that during the trainings, care the fight, tactical field care, and so on. Combat application tourniquet, you're going to tell me, no, but we don't need that in the civilian sector. Trust me, during the attacks that we had in France and that we had in Belgium, in Zaventem and in Malbec, some people have been saved by combat application tourniquet. So it also works in the civilian sector. Clinical practice guidelines done by the trauma registry, by the American Military Trauma Registry. This is the basis of the ATLS and the European trauma course. They are using the same basic principle coming back from the military trauma registers. Damage control resuscitation, fight against lethal triad, hypothermia, acidosis, coagulopathy. It's typically military, and of course, it's now used in a civilian setting. Massive transfusion protocol. So, what is the relationship between military medicine and civilian medicine? War induces, as I already told you, technical progress. So, we will have civilian research during the war with military money. That's the perfect combo. So, because you will have civilian military cooperation with researchers, technician, manager, and very important, reservists. I mean, civilian eyes going to work into the military world with new ideas, with fresh ideas. And that's maybe the best advantage of this cooperation. Also, when we decide something inside the army to implement a new protocol, everybody will follow this protocol. In the civilian, it depends on the people. Some people will do it. Some head of departments will say, no, I'm not interested. In the army, you don't have any choice. When we say, from now, you're going to do like that, and so you have a big scale implementation of protocols. And of course, we have all the trauma registers data. So now, in order to finish, I'm an anesthesiologist. I made my formation was graduated from a university, a civilian university. What does an... Microphone is mute. That's awful. No? No problem? Okay. So, what does an anesthesiologist in the civilian is doing a lot of things. This is not the goal, this is not the purpose to talk about my civilian life. We are doing a lot of things about peri-operative care, peri-operative management in the operating room, but also in the emergency department and the ICU unit. What is a military anesthesiologist? A military anesthesiologist must be the same, but more. Do we need to be muscle man? Please, have a look at me. No, I'm not a muscle man, but I can run if needed. I can carry my backpack, and I can fire with a gun if needed. This is what we need. We don't need to be muscle man like these people. If you are like that, you have a lot of muscle, you don't have any brain. We need brains with some technical skills, no muscle man. And we used to work in an austere environment, sometimes with safety, security problems, security issues, and with limited medical supply and very, very small logistic footprint. And from time to time, we are authorized to do humanitarian. We are not dedicated to do humanitarian, but we are human being, of course. And if we have the authorization, we will perform humanitarian medicine. In Belgium, the training of a military anesthesiologist, this is 6 years in order to become MD or a medical doctor. Then after the residency in the civilian sector, 5 years. And we always ask a fellowship in ICU or in emergency, so I mean a 6 year. How can we work in the civilian sector, half-time civilian sector, half-time military sector, but my colleague will explain that later. When we are not in military missions, of course, we have to do something. And what are we doing to do? We stay working in the Queen Astrid Military Hospital at the burn center. All the anesthesiologists are dedicated to the burn center when we have to take in charge small children, adults, and so on. It's absolutely interesting. It covers the full spectrum of perioperative care, but we don't have any trauma. It is not polytraumatic. So we are making damage control resuscitation, but this is not comparable to the polytraumatic patient that we encounter during operational missions. So this is good, but this is not enough to maintain our technical skills. And in order to finish, I will give you some examples, personal examples. I never talk about the other experiences. All the pictures are personal pictures, and I will talk about my personal experience. For example, I've been in Lebanon. We had a small hospital. This is a small hospital with emergency room, 2 beds ICU, 2 operating rooms, and so on. That's not much, but that's enough. We have only 12 beds. You're going to tell me, but okay, it's too small, it's too limited. Yeah, but the concept is that from the moment that the patient is stabilized, is operated, he will stay some hours of maybe 2-3 days, and after that, he will be evacuated through the medical chain. So the patients are not supposed to stay for weeks. Compared to the civilian sector, there is a big difference. There is a major difference. And you're going to tell me, okay, you are there only to treat the military guys. No, this is not true. If you have a look at the Role 2, Role 1 is general medicine. Role 2, this is second line, specialized medicine. You see the number of Bellefield and Unifil. So these are military guys and these are civilian. So we treated much more civilian guys than civilian guys and military guys. The same for damage surgery. We performed more surgery to civilian guys because it was authorized to do humanitarian medicine. It was very interesting because we made the full spectrum of perioperative care from pre-hospital, triage, operating room, ICU, ward. So I really enjoyed this mission. In Kandahar, I went 2 times in Afghanistan, I already told you, and the second time it was in Kandahar in a multinational Role 3. Multinational means American. Yeah, you know what I mean. And it was a big-scale hospital with scanner, with neurosurgery, so comparable to an academic hospital in Europe. The anesthesiologist was only responsible of the airway control during the trauma bay. In the operating room, it was only anesthesiology, but as you see, it was anesthesiology to critical patients. This is not in order to make propaganda. We saw several patients like that every day. It is not one patient every 15 days or every 2 weeks. No, it was maybe between 2 to 10 patients like that every day. It was very, very busy period. And as you see, I already told you about the combat arterial tourniquet. You see, this patient, for example, if he comes to the hospital without tourniquet, he will be dead because he will lose all his blood and he will be empty. And he will die. So the combat arterial tourniquet, it works, it saves lives. Also classical from lesions, from ID, mine, explosion, and so on. Patient with triple amputation, terrific, huh? Young patient, maybe 25 years old. Huh? He lost 3 limbs. Typical lesion, because I don't want to show you the picture of the patient, but this is the CT scan. You see the in and the out of a bullet, and the patient survived. And you see a small hole. This is the in, this is the out, coming from the commutation of the bullet. So you can imagine all the internal lesion of that. And that was business as usual for us during 1 month. Last very interesting mission I would like to talk about, it was the SOST. We were deployed in Iraq, in the northern part of Iraq, during the Battle of Mosul. when the Kurdish guy and the Iraqi guy took back Mosul. It was a SOST, Special Operations Surgical Team, very, very interesting because it's a very limited, very small unit, and we are supposed to perform all the spectrum of damage control, resuscitation and surgery. You see, this is the operating room. This is the material to be used in an operating room. We can deploy that in 2 hours. Initial operational capacity, 1 hour. Full operational capacity, 2 hours. 6 people, 1 liaison officer, 1 trauma surgeon, operating room nurse and technician, 1 anesthesiologist, and 1 emergency and critical care nurse. So 1 liaison and 5 specialists. And what are we supposed to do? This is my hospital in the civilian sector. You see, when I'm performing anesthesiology, this is all the devices that I have. A lot of technology, that's beautiful and so on, and we can perform brain surgery, heart surgery, and so on. This is what I had in Iraq. We could be inside of a building or in the tent, and it was my monitoring and the electric pumps that I had. You can imagine. And we did a great job with that. But you need to be very polyvalent to do it. So you see another example coming from the civilian sector. You see everything is beautiful, very nice, organized, and so on. This was my anesthesia table in Iraq. You see inside the dirty walls and so on. But we use what you get. In the SOST, we do damage control surgery, damage control resuscitation, but we are not going to lose any time. Some pictures, some personal pictures from Iraq, you see, always the same stuff, multiple amputation for young guys, very difficult for life, very difficult for that. Sometimes very complex situation because you are supposed to work only with your technical and manual skills. We don't have fiber optic, you don't have all the beautiful devices that you have in a civilian hospital, and sometimes it doesn't work. We try, this is what we call a clamshell thoracotomy to save the patient, but sometimes sometimes you succeed, sometimes you lose, and that's really awful. So, personal conclusion, anesthesiologist is a perioperative physician, but a military anesthesiologist can be and must be much more. We are pragmatic and boots on the ground people. I think you understand that. A good military anesthesiologist must be a good civilian anesthesiologist. A good happy anesthesiologist is versatile, is polyvalent and clinical. G.I. Joe anesthesiologist is bullshit anesthesiologist. So if you see a lot of people with a lot of muscles and so on, all the time that they are wasting to a beautiful muscle, they are losing it to entertain their technical skills. And I can be your best friend or not. Take-home messages for me, a military doctor, the versatility, the polyvalency is required and is in fact essential. You need maybe some skills about leadership and communication, maybe a little bit than in civilian sector. You love to travel and to be, you really love to travel and to be flexible. And from a personal life, it's not always easy, trust me. But you have the possibility to have an evolutive career development, maybe more than in civilian sector. I started as GP, I was anesthesiologist, then emergency doctor, then ICU doctor, and now I'm doing mostly training and education. So you see, it's quite changing. And what we need mostly critical care medicine specialists, anesthesiologists, emergency doctor, acutist, and so on. The core business of the operational medicine, this is the damage control. And I thank you for attention, and I give the floor to my colleague. Hey, Rob.
Good morning. I'm Major van Hove, Eva, and I'm coming to tell you about how you can join us. So, little introduction about recruitment and selection, about the education and the career possibilities. As my colleague already told you, our core business are the missions abroad, but we are not all the time away on the medical operations in foreign countries. We're sometimes also in Belgium, and then we're busy with troop readiness, medical fitness of our colleagues, and the courses who are given at our competence center. This is the big picture, how it starts at the point of injury, where we'll do an evacuation to the role 1, where we will see the first doctor, then 2 forward surgical elements like the SOST, where my colleague worked, or you can go to a role 2 basic or to a role 2 enhanced. The role 2 basic is the hospital like we had it in Lebanon. A role 2 enhanced is a much bigger hospital. Sometimes, like the operation we had in Afghanistan, you even will have a role 3 hospital, and that's much bigger. It will have all specialties like you will find them in Europe or in the United States, and you will find a lot of specialists. Most of the time it's mixed and not only one country, or it will be the US who will have a big possibility, but the other European countries, they will have to work together. Then we will go to the casualty staging unit to go back home by airplane. Who do we have at this moment at the Belgian army? We do have about 50 military doctors in primary care, surgeons, anesthesiologists, and others like intensivists, RX specialists, and some who are still on studying. Then we have not a lot of dentists, so we are still looking for dentists. Pharmacists we will find every time when we need them. There are enough pharmacists in Belgium to join the Belgian army, and veterinaries, it's not very much a problem also. We have in training on this moment some more, because we had just about 30 young doctors who started their military training. At this moment they are in Elsenborn for their basic military training, and they will start at Belgian University over the whole country at the middle of September, beginning of October. And we have also 2 dentists who are still studying and 3 dentists who are at Elsenborn military training and who will start their academic training in September. How can you come to Belgian Defence? Normal recruitment, then you have to start your first bachelor at university. Complementary recruitment, you finished already your first or second bachelor, and then you join the Belgian Defence. Or special recruitment at the first year of specialty, that's only for emergency doctors, acutists. We only ask for Belgian Defence the first 3 years. Or if you're anesthetist or surgeon in second, third, fourth, fifth, or sixth year, you can also join the Belgian Defence. And on veterinaries, pharmacists, when they have finished their studies, they can join also Belgian Army. Limits of age. And then we have lateral recruitments, but that's for persons who already have some experience in civil sector. Then you can enter Belgian Defence and you go in one time a whole way up, and you enter at after a period you also become directly a major. So the others will go the whole career up from soldier when they start at military phase to a second lieutenant, and then it will take about 25 years before you, 25 years before you become a major. If it's through lateral recruitment, then you will be a major in 2 years. What kind of selection we ask from our candidates? There's a medical fitness, psychotechnical test, sports test. There were no sports tests last year because of COVID-19, but normally everyone has to pass the sports test. There's a language test. There's a motivation interview, and you have to pass the entrance test at the university. So we'll ask that you were succeeded at that test and that you were at a good level to start also studying for the university. For everybody, it starts with military training. Basic training, 6 to 10 weeks. It depends how you will enter. Is it through military academics? Then it starts with 6 weeks, and then you go to the university, and the rest you will follow during the years. If you will go and you will enter immediately after your graduation, then you have a longer period of military initiation before you start your university and academic training. Specialized professional training, it's only when you finished your academic trainings. We don't have our own university, so you will go to the civilian universities in Belgium. A master in medicine or a master after master for the specialists. What do we ask for? What are we looking for? General or emergency medicine, surgeons, traumatologists, anesthesiologists, and sometimes we need ophthalmologists, infectiologists, radiologists, but not every year, because then we have too much of those specializations. So those places are not asked every year. The other ones, we don't have enough anesthesiologists, we don't have enough surgeons, so if you're interested in that, you can do it through defense. We collaborate with universities in Belgium, Dutch and French side, to make a training concept, part of it in the second language, part of it in English, and part of it in your mother tongue. For special recruitment, directly after the third master's, you go in emergency for 3 years. And there we have a plan with Brussels, Antwerp, and Birmingham in the United Kingdom. Or you can join us if you already finished your first year of specialization. Physical, there's a test every year, and it's your own responsibility to keep up your physical condition. You can ask and come to the responsible militaries for your education to help you if you have problems, but it's up to you as a doctor, as a student, as a military to keep up your physical condition. Languages, everybody has to succeed an exam in the second language to become an officer. We will have courses to prepare you, and then you will do the examinations. This is an overview of the academic of the different, the bachelor years, the masters, and the specializations. When you have medical training, medical summer camp, internship in our military hospital, when you have language courses and supplementary military training. Your career, if you're a primary care officer or specialized care, it's always put out in 3 parts: territorial, operations, and the complementary training activities in the civilian sector. So for the primary care physicians, it's in the territorial centers over the whole country, and you work as a general practitioner or an emergency doctor. You will be responsible for the medical readiness of the medical component and the other components. You will go on exercises, on training, and on courses in Belgium and in the rest of the world. You will go abroad 2 months. It's the ID for the primary care physicians, and to work in the continuum of care. And most of the time it's general and sports medicine, but 10% of the time you have really emergency cases where you have to intervene. Complementary part, so the doctors will work here at the role 1. But to keep up your skills, it's not enough to work only in the military, because we don't have all the time trauma care. So what do we ask from our doctors? To go work in emergency services in the civilian hospital, or to work as a general practitioner with civilian colleagues. And it's about 60 days a year that they will go to the civilian side to work. You will have an extra salary that's paid directly to the physician. For the specialized care physician, it's almost the same thing, but they work half-time in the military hospital, in the burn center, or in the center for the medical expertise, or you will give training and courses. That's also a possibility in your career. You will go on a mission abroad, damage control surgery, like my colleague explained already, or for the specialists, it will be in a Role 2 enhanced, or in a Role 3 in international collaboration with other countries. So this part of the military chain for the specialists. And in Belgium, you will keep working also in civilian hospitals to keep up the competences. Like my colleague told, military anesthesiologist alone is not enough. You have to work also in civilian sector to keep up your skills. This is a picture of our students of the past years. So it looks a lot, but it's not already enough. We are looking for a lot more people in Belgian Defence. So if you're interested, you can always join us for other questions. And there's also the Recruitment and Selection Center of Brussels is present in this building, so you can ask them also other questions. We don't only ask for active members, but also for reservists, so that's also a possibility. Thank you for your attention.